Mysuru. Uh, yeah, so she has been very um, she's been a pioneer in pain medicine. She has been a voice for a lot of pain physicians, and she has done tremendous work in bringing up the society, especially in terms of the academy, in terms of its educational value and the way it is now in holding the examinations. She's conducted a lot of exams for FIAPM. She's been the examiner multiple times. Madam has also been a recipient of low cost effective awardee. She also has acted as the president elect for the ISSP chapter. She has had numerous publications in international journals as well as national journals, and she's a regular and very frequent invited speaker for a lot of conferences in India and overseas as well. Not taking too much of time, I think I will leave the stage to you, ma'am.
Yeah.
Please do the next.
Thank you so much, Swati. And this was surprising. I never knew that moderator will be introduced in so much of details. So, but it is very warm and nice to hear those words from coming from you, Swati. Thank you so much. And so today we have the topic is one of the most important, and personally for me also, it is like one of the very dear to my heart is the topic that is shoulder pain. And we have Dr. Madhan Pandian. I don't have his formal CV slide, which I can read, but I can tell that Madan is one of the passionate person when it comes to shoulder interventions. I'm sure most of you must be following him, and you can see the amount of passion he has. He will never leave an opportunity where he can talk about or give knowledge, share knowledge. And that's one of the best things I find about him is whatever he's been doing, he really likes to share that with the with everybody. Especially, he always encourages the youngsters, and he since he's been doing it with so much of a passion, I think he has developed some of the techniques of his own. And so we cannot have any better person than Dr. Madan to talk on this topic, that is shoulder. But I'm sure not only about the intervention part, but he is also going to talk about the differential diagnosis and the evaluation of the shoulder pain, because it is one of the complex conditions and it definitely requires somebody who is an expert in this area. And I'm so happy that we have Dr. Madan Pandian for this topic, who's going to do more than a justice to this topic. So over to you, Dr. Madan. And just wanted to tell Dr. Madan that I'm actually yesterday, since the topic was decided yesterday, today I have some commitment, so I may not be there in between. So
no worries, no
please manage yourself.
It's not
Yeah.
going to be a
Thank
long
you so much.
session.
So over to you. Yeah.
Okay, madam.
And what I would
Right.
like to suggest is, Madan, if it is not
Yes,
possible for you to finish the whole thing, because that is what I did last time, because it's a very, very big
Okay.
topic, you can take 2 sessions. If you want, you can take it some other time, and but take it at a leisure time so that the students will get benefited with it. Yeah.
Sure.
Okay,
Sure.
over to you.
Okay, right, sure. Right. Yeah. Good evening, everyone. Thanks for the introduction. Actually, like as Madam said, roughly section, it is a very common presentation. Need to means like you should not do a generalized diagnosis of a frozen shoulder. That's the first point which I will always insist. Do a good clinical examination. Once you get a good clinical examination going, you understand, okay, what am I going to focus on my ultrasound examination? So there is another thing which I want to highlight here is when you have a probable diagnosis when you enter into the ultrasound examination, you need to also make a diagnosis based on your ultrasound exam. Do not ever, every time try to go for a MRI. MRI is one area which probably you don't require that many MRIs. It's not like your spine actually. You can make a lot of data on examination. But again, a lot of people go from you as an intern, you need to shoulder ultrasound. This is the disclosure. I don't have any financial disclosure or conflict of interest. All these are ultrasound scans and videos are based on my original work shoulder. Now, all of us know that there is, and that is nothing but the ESSR protocol, which everybody follows now, right? What are the targets for pain interventions, the evidence for these different interventions, the side effects and complications associated, and what are the limitations of ultrasound in shoulder? So why do we scan? We also need to know why we scan, how we scan, and what are all the potential utilities of scanning. There is something called diagnosis. Everybody must know how to make a diagnosis. What type of tear? Is it a tendinopathy? Do a 360-degree dynamic examination. Try to find out what maximum you can gain out of an ultrasound examination. Make a diagnosis based on the clinical and the ultrasound examination. As I always keep telling you, acquire a lot of images and videos, play it again. In the night, I usually take the entire set of review all these images so that you have a better diagnosis, so that you can plan your entire, and you can either an intervention or a study based on ultrasound findings. The type of intervention also matters, and this is more dynamic because you can't get a dynamic examination of the MRI. So introduction to the assessment. So as always, every one of us know that there are ESSR guidelines for what's called departmental protocols and guidelines, which always you must do. Before doing all this, what you must understand is you must be very strong at your anatomy. If you don't know the anatomy well, probably what you may end up with is making a wrong diagnosis. For example, recently I had a person, actually a very senior person, who sent me an ultrasound image saying that this is a subscapularis, supraspinatus rather. So what is the difference between a supraspinatus and a subscapularis? You should be able to find out the difference between the profile of the acromion, which is likely to be a little straighter, and the profile of the coracoid, which is likely to be an inverted C. So you just imagine, you make a diagnosis that this is a supraspinatus, and you on the table, you see there is a tear on the subscapularis. It's going to be really like, like you will have to change the entire plan. So that is the reason why you need to know the anatomy well, understand the justification to make a clinical question. You yourself ask a question. When you see a shoulder patient, ask a question to yourself, sound examination and the clinical examination, formulate a report. You make a report based on all these findings so that you have an answer for the clinical question, and then you get to know what intervention to be done to this patient. No, there are plenty of scanning guidelines. I think like the ESSR scanning guidelines are just the basic. I'll say like it's not the, it's not the, what to say, these are only guidelines which everyone must start following. But as you grow with scanning, a lot of scanning, then you understand that those are only those very early days you will require this ESSR protocol. So there are other guidelines like the ULAR guidelines, the AAUM guidelines, all these are newer guidelines. Small subtle differences, but it will make a huge difference when it makes to getting a right diagnosis, right? Say for example, a patient who is presenting with an adhesive capsulitis, the ESSR protocol says do an examination of the rotator cuff with a cross position. Are you able to, will you be able to do a cross position? Definitely not. So what you need to understand is you need to actually choose the right way to scan. Sometimes the patient will be supine, sometimes the patient will not be able to sit. All that you will have to take into consideration and make your own way of scanning each and every patient who is going to be unique. No, this is the scanning protocol. As a pain physician, you must look beyond the is the These are the standard guidelines. No wonder you need to learn only from this protocol. But this doesn't highlight any underlying pathology or dynamics. And there are certain nerves which need to be included. Those are not discussed because this is the ESSR protocol is beyond the scope. Means like it need not discuss about these interventions and the smaller nerves. Now, before we enter into the scanning part, you should know what are the red flags. So there are quite a lot of these red flags. All of us are aware: trauma, tumor, infection, cervical radiculopathy, and a weakness. See, two important things. This is one video. This is a maxillofacial surgeon. You can see he comes with a little bit of weakness. You could see there. Beyond this 30-35 degrees, he is not able to do the shoulder abduction. He is able to do the cross and the modified cross positions comfortably without any pain. But as I ask him to do an abduction, see, the external rotation is full and complete. There is no evidence of a shoulder disease here, right? So now what we need to do is you need to rule out a cervical radiculopathy. So which I want to tell you. Now I support him. Trying to support him is able to do a proper shoulder abduction overhead. So there is a weakness here. This patient classically requires an MRI to rule out a cervical disc pathology. Whereas this patient this is because of the rotator, right? So you must this patient also requires an MRI. This patient on the left who requires a MRI of the cervical spine. On the right, this patient who requires a MRI of the shoulder because he has got a rotator cuff tear, the full thickness or a complete with tear. So how do I'll just change just a moment. Yes. Am I audible, ma'am?
Yes, sir.
Yes. Okay. Right. So you need to scan the biceps in two axes, both in the axial view of the tendon and the sagittal view of the tendon. It is very rare to have an isolated biceps pathology. So when do you get these biceps patients? Usually they go for gym activities, sports activities. Patient who had a fall with an outstretched hand, with the elbow hitting the ground. See, you must also in sports injuries, the most important thing is try to find out the mode of injury, how exactly the patient fell. Ask him to actually do the same thing again so that you understand what was the type of injury. Was it a flexion injury or is it an extension injury? So a couple of days back, there was a university basketball player who had a elbow pain actually. Means like because of a fall. It was a triceps tear. So you must know what is the attitude of the limb, what is the type of fall, everything must be really taken into account and then do the scanning so that you get to understand what pathology you will anticipate. So it is very rare to have a biceps pathology unless there is a trauma. Don't ever think a small little effusion because secondary to adhesive capsulitis, you might have a small little effusion in the biceps groove. Never take it as a means biceps tendinopathy. If there is a biceps tendinopathy, try to put in color Doppler, try to examine if there is any neoangiogenesis, try to see if there is any fluid around, if there is any swelling of the tendon, if there is any long axis of the tendon, you see if the fibrillar echo texture of the tendon is lost. All this need to be taken into consideration. right? This is how exactly it looks like. There is a small little effusion with the picture on the left side, and there is a bigger, you can see this. This is the tendinopathy. You can see the neoangiogenesis. There is a swollen tendon, and this is the patient who will require a PRP preferably, or maybe a steroid injection. Whereas the patient who is on this side is a small effusion, which definitely is not correlating with anything called a biceps tendinopathy. The one which is on the right is the biceps tendinopathy, right? And very characteristically, what you must understand is this, right? The findings are the tendon is thickened, tenosynovitis is there, there is a hypertrophy of the tendon sheath, and there is fluid surrounding. The diagnostic accuracy is around, what to say, the specificity is around 100% with ultrasound examination. Right. Now, with respect to biceps, there will be plenty of findings. Small injuries, there can be a small tears of the subscapularis, because of which there is a, means like you can see, there is an intertubercular groove over which you have the intertubercular ligament that gets disturbed, that gets torn, and there is a small subluxation of this tendon, which secondary to all the movements, the flexion movements, it gets subluxated every time you do a flexion. So all this need to be dynamically examined. When you see that, sometimes it might be just within the pocket, and when you do a proper flexion, it might just jump out of this pocket. So all this need to be examined. Somebody is, yeah. Someone, you can mute yourself, please. Yeah, thank you. Right. Sorry. Right. Now, this is the rotator interval. All of us know that this is gaining much significance because of this is emerging as a treatment of choice for any patient with adhesive capsulitis. See, this is how exactly the rotator interval looks like. On either side, you have the supra and the subscapularis. And in between, you have the long head of the biceps. You have the coracohumeral ligament and the superior glenohumeral ligament, superior and inferior glenohumeral ligaments. And exactly, you need to actually pierce this coracohumeral ligament, come closer to the biceps tendon, and then do the injection for your rotator interval hydrodilation. Now, before this video, I just wanted to show you this. Actually, it's like all of, when you see this cuff, you should look, it should not be a puncture tire. If it's a puncture tire, then you must see that there is a probability of, what to say, like there is a bursal surface tear, and that is the long axis of the, means that's the long head of the biceps, the intra-articular portion, and there is a small little space. And look for the contour of these particular things, the tendon, then your ligaments, your tendon, biceps, or if there is any cortical tears, everything can be evident. One thing is for sure, unless you may not be doing a perfect rotator interval injection. This is a subacromial bursa injection, rotator interval on the other side. I'll show you, right? This is entering into the small little bursa, okay? Slowly inflating it. Slowly. Typically use very small volumes. I use a 26 gauge needle for injection. So there will be a lot of pressure which I exert, okay? A little bit of pressure will actually inject the fluid inside, but you need to be very clear about usage of lots of volumes. Use very little volume so that you open up that space. Then there is a AC joint. Why I will say AC joint? Usually books tell you to go for the rotator cuff in the second scanning. After the bicep scanning, you go for the second scanning, which is the rotator cuff. But I always say, if the rotator cuff is a little bit swollen here, the rotator cuff material which is getting collected here, which is called the Geyser sign. Clinically, both by clinical and by ultrasound examination. Then there is always this something called the Geyser sign, which suggests that the rotator cuff material has leaked into this joint, means that there is an underlying pathology in the rotator cuff. So it can actually be a positive predictor for trying to find out if there is a rotator cuff pathology or not. Just now we discussed. See, these are three different types of AC joints. So you can see there is an AC joint here. The one which is riding above, the higher riding bone is the clavicle, and this is the acromion here. And you can see the AC joint, the capsule, everything. Here you can see there is a small little osteophyte sitting there. And there is a lot of echogenicity here, which is suggestive that there is an underlying cuff tear. And this is a person who is an elderly patient, lot of means like with lot of osteophytes, both on the sides of the acromion as well as on the underlying surface of the acromion, on the clavicle and the acromion, both actually. So this suggests difference. This is an youngster. This is again an youngster with a little bit of rotator cuff tear. So that the cuff material getting leaked there, the Geyser sign, and this is an elderly patient. So you must actually identify how exactly the AC joint looks like and then proceed for the rotator cuff, because you will understand whether there is an underlying pathology or not, right? Then there is something called the impingement testing. You need to focus on the acromion here. Try to do a shoulder abduction. Try to find out if the rotator cuff gets underneath the acromion without any impingement, which is called the sonological impingement testing. You need to understand, never follow only the textbooks. Textbooks are going to give you only the guidelines. You are supposed to innovate every day. You scan a new patient, you are going to innovate and then try to make a new protocol for yourself, right? Now, there is something called the shoulder impingement syndrome. A lot of you must be seeing this particular case. There will be a painful RSL, and the shoulder impingement accounts for the maximum number of the shoulder complaints. So, which are the patients? Different patients do present with different syndromes, means shoulder impingement syndromes. A diabetic will be a young, means like a middle-aged adult. A sports injury will be a young adult. There will be an elderly patient who will be actually having impingement because of the AC joint arthritis. All these different subset of patients you will be seeing. Never treat all the patients alike. So subacromial space. So there means this subacromial space will be inflamed. Means like there is a bursitis. It could be a rotator cuff disorder like a tendinitis or a tear. Sometimes it could be a calcific tendinitis. All these patients do present with the supraspinatus getting underneath the acromion, means that will cause a lot of pain on doing the abduction, shoulder abduction. Then supraspinatus. Now, this is something which I always want to insist actually. Crash and modified crash positions are advisable only for volunteers. Mind you, you will not be able to do this crash and modified crash, what is explained in ESSR protocol. Definitely not able to do, particularly in patients with severe stiffness. So for which, what I suggest is, I think there is a name for it. I don't know, like what, I don't remember the name. But what I do is, am I seeing here? Yes. Somebody can just if I'm seen or not. Is my limb position seen, madam? Somebody can respond, please.
Yes, sir, you can be seen.
Yeah. See, this is how, instead of keeping it like this, keep it neutral. That's all. Okay. So this basically, like all the patients who has got the most stiff shoulders, you can actually do this particular maneuver. And doing this particular maneuver means that you can see the entire subscapularis and your rotator interval. You can actually imagine quite a lot of things, what exactly has gone wrong in this patient. You can see the entire cuff. You can see the entire cuff. and then make a probable diagnosis. So do we need crash? Definitely not. Definitely. So that's why I keep telling you, when you see a patient, you can actually try and innovate, right? So what all you can see like a tire, you can see like in the long axis of the tendon, this is how the long axis of the tendon, you can see pathologies like this. If you see the tire, you can see calcifications, tendinopathies, everything can be made out. And not every time you will see a bursitis like this. Sometimes you may be lucky seeing a fluid, but in case if you don't see a fluid, does not exclude bursitis. Sometimes you'll be seeing this small little fat stripe which will be thickened, and there will be a neoangiogenesis, there will be an increased vascularity, everything will be here, right? So those are the things which I try to tell you. So something which everybody needs to understand, right? Just one moment, I'll just get back. Yes. So subscapularis, all of us know how the subscapularis originates and inserts. It inserts onto the lesser tuberosity and originates from the anterior surface of the scapula. But here on the anterior surface of the scapula, you need to do a proper external rotation to try to find out only the tendon. You can see the tendon, a little bit of the myotendinous junction, right? So how exactly? This is again another problem actually. Everybody can see subscapularis, everything you can do. But on a patient who is having an adhesive capsulitis, it is one of the difficult things to scan because the patient will not be able to do any kind of external rotation, right? So you can do a dynamic examination. Again, this is possible only with a volunteer. This is another patient, right? There is a small subcoracoid bursitis, which can be unveiled only if you try to do a extreme external rotation, so that when you do an extreme external rotation, you will be able to find out the pathology, right? Right. Now we go to the infraspinatus and the teres minor. So infraspinatus, all of us know that you go and see the posterior joint recess, and you can see the the infraspinatus getting inserted there. The very same patient, I'll tell you, the very same patient actually, infraspinatus, everybody looks at it, you think it is very normal. See, the entire tendon looks normal, echo pattern, everything is there. There is no fluid, everything looks normal. But till the time you do a proper dynamic ultrasonography. I think none of you would have expected this particular tear in the infraspinatus unless you see a proper dynamic examination. So this is very, very important to do a dynamic examination. So for which you must need to know the anatomy, the functional anatomy, all these tendons, and try and find out what exactly the pathology could be. Right? The infraspinatus and the teres minor both together, the infraspinatus and the teres minor here. You can see this is the teres minor, and posteriorly on the arm, you can see this is the teres minor, and you could see the quadrangular space where you have the posterior circumflex humeral artery and the axillary nerve. So the posterior structures of hydrodilatations. Here, what you need to know is the tendon, what is the contour of the tendon, ecotexture, and this is the joint space. You can see there is a little bit of thickening, that capsular thickening is there. That indicates that is early capsular thickening in adhesive capsulitis. So there can be a small little effusion also. That also indicates there is a likelihood of a joint effusion, means that more likely it is an adhesive capsulitis. And this is the notch, that's a suprascapular notch. Posteriorly, you have the trapezius, supraspinatus. So all these are scanning. I think I'll teach you on some other day, right? And you can actually keep two targets for your suprascapular nerve block, the supraspinous and the spinal glenoid notches. And you actually can go to the glenoid, upper part of the glenoid, for your articular branch blocks for the suprascapular nerves. Now, how do you do the interventions? Basically, what you need to do is, textbooks do prescribe only out of plane technique for your biceps injection. So you can see the biceps tendon. You should never disturb the tendon. You just inject around the tendon. Okay. So always when there is a small little effusion, don't aspirate the effusion. The aspirating the effusion means that you can actually show that I have aspirated 0.2 ml. Don't do that. You always ensure that if there is a lot of fluid, aspirate some fluid, and that fluid which is around the tendon, which is actually going to be your cushion for injection. So use that cushion, right? And there is something which I always use this way. There is an in-plane technique. By doing a slight external rotation, you have this, means like the greater tuberosity actually comes away and you can do a proper in-plane injection into the biceps tendon sheath. Right? There are plenty of evidence. There are plenty of evidence for PRP. Means that any patient with a tendinopathy, you need to actually use up a PRP injection. But steroid still remains a common injection. Where all steroids must be avoided, you always try to avoid steroid injections close to the artery. There is a small little artery which is there on the, mostly on the closing, abutting the greater tuberosity. So that which needs to be avoided, because there is always a technical chance that the patient might have a steroid embolus. And secondly, if there is already a fatty degeneration, lot of tendinopathy is there, I think there is really, like, it's going to be worthwhile going for a PRP injection than a steroid injection. So lot of evidences, but the success rate with respect to injection with ultrasound guidance is 100%. So any patient with biceps related intervention, you should always do it only with an ultrasound guided, be it on the, means like in plane or an out of plane technique, right? Again, lot of literature saying that there is good evidence for treating with PRP. There is a level 3 evidence here. So lot of studies emerging still, right? Now there is a subacromial bursa injection. So I showed you another injection previously. There is another injection. This is on the long axis of the tendon. You just try to hydrodissect that small little space, then slowly open up that space with a little extra pressure. Means like you enjoy your injections. That's most important. Any of these MSK interventions. See, you can see it on the long axis of the tendon. This is the short axis of the tendon. See, the injectate might vary. There is a tendinopathy, you can use a steroid, you can use a 5% dextrose or anything you want. But technically, where you enter, how you exactly go in, these all really matters. For which you need to know the in and out of imaging. Good imaging means that good interventions. Right? So there is lot of evidence for this subacromial bursa injection. So where all you can use subacromial bursa injection is, one, when there is a rotator cuff tendinopathy, and secondly, if there is a bursitis. If there is a bursitis or a tendinopathy of the rotator cuff, definitely it is worthwhile going for a subacromial bursa injection. Again, I decide if it is a tendinopathy, you can actually put in a dextrose, 5% dextrose, which is good enough. If it is a bursitis, if there is an inflammation, then you can actually go in for a 10 to 20 milligrams of steroid. Don't use 40 milligrams of steroid just for the subacromial bursa injection. If you have a triamcinolone vial of 40 milligrams, try to use it very, very cautiously, about 10 milligram for your AC joint, 10 milligram for your subacromial bursa. And if it is going to be for the joint, 20 milligrams are good enough. If you are going to do a proper injection, ultrasound guided, target guided, definitely yes, good enough. So this is how you do an AC joint injection. Again, the volume should not exceed 1 to 2 ml. You can do an in-plane or an out-of-plane injection. Textbooks do prescribe an out-of-plane. I personally ask you to do an in-plane technique because of this reason. See, you all know that there is a clavicle and this is the acromion. The higher riding bone is always this clavicle. I have seen plenty of references coming to me for osteolysis of the lateral third of the clavicle because of inadvertent injections of steroid. So this is an important complication arising out of either an ultrasound guided or a blind technique. There are even ultrasound guided techniques which are actually going wrong recently. This lateral third of the clavicle getting osteolyzed means that it has to be operated and excised. So I think like this is one of the very terrible complications to face. So you need to be very cautious that your needle at no point should be touching the lateral third of the clavicle. Again, one of my very favorite procedures long term, using a hydrodilatation of the saline. This is for treatment for adhesive capsulitis. So basically, this was the technique which I was following for years together, trying to put an in-plane technique actually posteriorly. And this fountain of fluid which is coming out directly indicates the amount of intra-articular pressure associated with an adhesive capsulitis. But later on, looking at the pathology, there is evolution of the literature. I switched myself to the rotator interval injection. Lot of conferences, lot of people teach only this particular technique. I kindly suggest you, I think a lot of you are there actually, lot of fellows are there. Please switch to a rotator interval injection for one reason, because the entire pathology is going to be closely associated. Am I audible?
No, sir.
Am I audible, sir?
Sir, you are not audible,
Yes.
sir. Sir, you are not audible, sir.
It's breaking.
Sir, the last thing we could hear
Am I
was
audible,
white.
madam?
No, your voice is
Am I
breaking in
audible
between.
now?
No, it's still breaking.
Just a moment, madam. Just a moment. I'll just change my network because I'll change to my broadband. Just wait. Am I audible, madam?
Yes, sir.
Okay, perfect. Right. Sorry. Now, this is something which I have been using for years together, but looking at the pathology, there are a lot of literature, new literature emerging on a regular basis, on a day-to-day basis rather. Audible, ma'am?
Yes, sir. We can see your slide as well as your audible.
Okay, right, madam. Sorry. See, this glenohumeral joint injection is really evolving. Initially, this was the posterior approach, which was regularly done by a lot of people. Then there was something called the rotator interval injection, that technically slightly demanding, but it is one of the most rewarding procedures because the patient is more comfortable with the patient is supine, and it is a smaller needle which actually enters into the point of pathology. So this is the pathology area. So you can see that that's the place where you actually want to enter. This is the entire tendon which you need to look at, and the rotator cuff should look like a tire, and then your needle can either come from lateral to medial or medial to lateral. I prefer coming from lateral to medial, right? I've just gone below the coracohumeral ligament there. Try to slowly inject. There is a very, very tight space. Not every patient will be the same. There will be some set of patients who will be having neoangiogenesis. So they are likely to have less fibrosis around the rotator interval. Such patients, it is very easy to inject. Whereas when a patient who does not have any neoangiogenesis here, likely to be that there will be a lot of fibrotic changes in the rotator interval. So such patients, it will be very difficult. I definitely initially was doing a lot of hydrodilatations with higher volumes, but the recent literature, how many of you have read this? I'm not very sure. The recent literature by Philip Peng, Nimish Methel and co, they said that the 10 ml volume of injection into the rotator interval is good enough for spreading till the axillary recess, so that you have lot of good pain relief just with 10 to 11 ml of fluid. You can use 1% lignocaine along with some saline, maybe 5 ml plus 5 ml, and then give 1 ml of kinacot. That is like for 20 to 40 milligrams of triamcinolone. That will do the job. Right? Lot of evidences are there, but there are something called capsule preserving and the capsule rupturing technique. I will always suggest you go for a capsule preserving technique because capsule rupturing technique is likely to be painful. But I'll tell you, there is something called hydrodilatation, large volume of hydrodilatation, that is also going to be beneficial because what does a surgeon do with an arthroscope is release the capsule mechanically, which you can actually do a release of the capsule mechanically with saline itself. So that's the goal with large volume hydrodilatation. The only thing is, if you do a large volume hydrodilatation, you need to actually use a suprascapular nerve block, so that if you do a suprascapular nerve block, it is likely to be less painful, right? And this is something called the SHAC approach. That's a shoulder anterior capsular approach. You can do a proper shoulder anterior capsular approach like this. The patient is supine. I'm just injecting just beneath the subscapularis. I'll just show you the scan this also. Right? Again, you'll have a good fountain coming out because that is reflective of the amount of intra-articular pressure. But I'll show you the scans, how difficult it is to actually enter into this particular space anteriorly, because you might need to go through the tendon. You can see there is a tendon, that is a subscapularis tendon over there, and you need to go into the tendon, which is likely to be tight, and you can't actually pass beyond this because the needle tip will be lost. Slightly difficult for the patient because the patient needs to keep the arm a little bit externally rotated. An external rotation in a patient who is actually having an adhesive capsulitis, I think you can imagine amount of pain, right? So this is one of, then barbotage is something, again, I'll take it in a separate class for barbotage. It's like that. That's a very, very important technique. Again, barbotage and hydrodilatation are actually these are two wonder techniques which any pain physician should know, because these are the techniques which is actually avoiding shoulder arthroscopies. Typically, as you said, if there is an endoscopic discectomy, you can avoid a surgery. The same thing, you can avoid a surgery with knowing barbotage and a hydrodilatation if you do it properly. Right? I'll teach you in a separate thing. Right? Suprascapular neuromodulation. Again, there are a lot of techniques available, anterior approach, posterior approach. And now the one which is gaining importance is, not much literature is available as of now. The one which is gaining importance is the articular branch, both by ultrasound as well as by fluoroscopy guidance. Again, I'll take it in a separate class. That will be a separate class. I think like itself will be a separate class. This is how we do the suprascapular nerve block. I've just demonstrated it using a nerve stimulator just for the sake of demonstration, right? This is the suprascapular notch posteriorly, and enter into the suprascapular notch. Here we can see the needle coming in plane. Slightly difficult to visualize because it is around, say, 4 centimeters depth. So you need to actually put in there. Inject under the transversescapular ligament after stimulating. Right? Role of regenerative medicine. Again, I've seen plenty of people doing this actually, trying to diagnose tears by using an MRI. Using an MRI, you can actually quantify the tears if you really want to subject this patient for a surgery. If there is the tendon integrity is lost, there is a complete with tear, there is a retraction of the tendon more than 2 centimeters on your ultrasound examination, those are the patients who might actually end up with a surgeon. So for which you need to do an MRI. Suppose you are going to do a small little intervention with a PRP or maybe even growth factors or exosomes, you need to be very careful. If you end up doing an injection based on your MRI, unless you know where the tear is, please don't inject. Please don't inject. There is really no point doing that actually. So a lot of actually, I do get at least some 10 references on a day from pain physicians asking for help based on an MRI. See, you are not going to do an MRI guided injection. You are going to do an ultrasound guided injection, for which you need to be very, very clear. See, specifically, I'm telling you, try to find out where exactly the problem is and then do an injection. Don't ever try to go ahead with injection without knowing the site of injection, right? So I think like with this, I basically will wind up here for only one reason, because this will be too exhausting for you. That will be a little too much, not just for the sake of learning. You need to understand the things as well. So let me stop here. The basic interventions I have discussed, and we will go for slightly advanced interventions in a separate class, during which I want to show you how exactly a barbotage should be done. Number one. Number two, how exactly you do a articular branch RF. So these are the two things, very important things which I want to show you. And one more thing is how to do a scanning. Scanning is very important. How exactly you can go, but I basically can get one or two of my patients. I can show you how exactly do a scanning also. So that is very important. Means making a diagnosis based on their scans. Unless you know a diagnosis, you basically can't treat, right? So that's how I wanted to sum up here. And means like any questions, please do ask me.
Somebody has asked, can we inject for slap and Bankhart's tears?
No, madam. No, you should not.
Okay.
That's a surgeon's case. That's a surgeon's case.
In elderly patients with complete supraspinatus tear retracted, what would be better, RFA plus regenerative or
Only RFMA, madam. No regenerative.
okay, or arthroscopic
Because
surgical repair?
that is what I keep telling actually. Nowadays there is a problem actually. Like the problem of plenty. Whoever is affordable, we are trying to treat them with whatever we have. That should not be the case. Ideally, try to find out, get the images, acquire all the images, try to review all the images. Then we know what we are doing actually. Then the results start coming. Because like I'm doing like almost on a regular basis, lot of shoulders I do. Every patient is unique. Every patient is unique in the sense. Today I did one patient, like I just thought like there is a small little articular surface lesion on the supraspinatus, because of which the patient has developed a disc capsulitis. Now, after starting to do a rotator interval injection, the spread actually went into the subacromial bursa. It is likely to be a full thickness tear. If it is a full thickness tear, then only there is a spread. So there is a lot of learning on a regular basis only if you start doing on these things. So very important to know the diagnosis when you do the scanning.
Right. Okay, another question. If the
Yes.
patient is having frozen shoulder with decreased range of movements in all directions and MRI shows partial tear of muscles and some joint effusion, then in
Yes,
that
ma'am.
case, how should we...
Treat the capsulitis first, because that is the most painful element.
So
Then once
the
the range
query
of
is regenerative versus nerve blocks or one after the other?
one procedure at that first time, means like you treat the capsulitis first, hydrodilatation, follow it up with a PRP with or without RF.
Right. How long should the interval between the two PRP sessions be, ideally?
Definitely 4 weeks, ma'am.
Right. I think most of the questions are answered. If
Yes, ma'am.
for a rotator cuff interval injection, just piercing the coracohumeral ligament is sufficient, or do we need to inject between biceps tendon and subscapularis bar supraspinatus?
No. The basic thing is, no, madam, like there is a small little oblique tendon which is there. Your needle must actually go through the coracohumeral ligament. That is number one. Second thing is sometimes it will be a little difficult because of the amount of fibrosis. For which what you can do is just try to go abut on the tendon, not entering into the tendon. Just abut on the tendon on either sides, whichever is feasible. Sometimes a lot of fibrosis can actually make the injection very difficult. So for which I always suggest, try to get in there, just abutting the tendon. Wherever there is a resistance-free flow, please inject. That's all.
I think most of the questions are already done.
Question, sir.
Yes, sir.
All the questions are done. Anybody?
Ma'am, I have a question.
Yeah.
Yes.
Basically, sir, I wanted to know suprascapular nerve block. Should it be done in the spinoglenoid knot or at the suprascapular knot?
Ideally, I'll tell you, instead of the suprascapular, you can actually choose to give the spinal glenoid notch. But as I repeatedly told you, there is really no fun giving a pulse tariff of this suprascapular nerve because it does not give that much of pain relief. Neuromodulation is not giving that good pain relief. The evidence is actually going down on a regular basis. That's the reason why we started getting this articular branch RFs. So articular branch RFs, even though it is articular branch also, you must choose the superior and the inferior glenoid posteriorly and anteriorly. That is what is called the articular branch blocks. So that I will show you the targets. Means I think that will be a separate session on barbotage and the articular branch. Those are very specific areas. Instead of going into the notch, you go touch the posterior glenoid and stimulate and then do the lesioning. So that is how it is done. The spinal glenoid notch or suprascapular notch, doing a pulse tariff because since it is a mixed nerve does not serve any purpose. I think it is all waning off. The techniques are actually going off.
Okay, sir. Thank you. Thank you.
Yeah.
So I think I think we are done with most of the questions. I mean, all the questions we have done. I think we can wind up the session here. Thanks a lot,
Sure, madam.
Dr. Madhan,
Thanks, madam.
for your time and expertise. So we'll once again connect with you over maybe.
Sure, madam.
We will see when that's possible to do, and probably you'll be covering.
I personally I think all these delegates. I think most of them are students. I think is it okay if I can teach you barbotage and rotator interval? That is good enough, or anything else? Any procedure they want to know?
I think RF probably will be.
Yes, articular branch RF,
yes.
barbotage,
yes,
and rotator interval. Yeah. See, rotator interval, I think not many people are teaching. That's the problem actually. So we'll teach them.
Yeah, sure. So we'll look into the logistics and how I look into the calendar and we'll see where.
Sure, madam. Sure, madam.
Yeah.
Okay.
Thank you so much. It's so wonderful listening from you.
Thanks,
topic like this, which is so close to your heart, I can understand that. And it's so very important as well. I mean, we do keep getting a lot of patients of this and they do benefit a lot. Thanks a lot for all of you. Thanks, let's wind up for the night and good night and see you next week.
Thanks, madam. Thank you.
Bye-bye.
Bye.